All right. Good morning, everybody, or good afternoon, depending on what part of the country you're in. This is Todd DeVoe with Vic Marginian, the CEO of Titan HST, and we welcome you to today's webinar, How to Reopen with Confidence During this COVID crisis. And I want to thank you all for spending your time here with us today. Just some notes here. Down here in the bottom, we have question and answers. If you have any questions, please feel free to type in your question. We will be looking at chat, but sometimes chat gets a little dicey as far as getting your questions in. So if you have any questions, please use the Q&A button at the bottom. Vic, welcome to the webinar.
Welcome. Thank you. Thank you for having me.
So, we're all looking at ways to get open again with this crisis that's going on. It doesn't look like it's going to go away anytime soon. Even with some good news with vaccines coming forward, it looks like COVID's going to be with us for a long time. And to put this in historical context, the strain A, the flu A, is the same flu strain that we had in 1918. So it doesn't necessarily go away. We just figure out ways of handling it. So Vic, with the technology that we have at Titan HST and other technologies that are out there, what are we doing as a nation and as businesses to help really kind of get back up? Well, I don't think we're ever going to be at normal, but at least reopening with confidence.
Yeah, so to reopen with confidence, I mean, I guess it's a two-part plan, right? I mean, we ourselves right now are working remotely and working to reopen, and there's a few different things going on. So first I'm going to talk a little bit about some of the institutional kind of setups. And with that, there's not a whole lot you can really do. But the other part of it is what you can do organizationally yourself to try to reopen safely. And, opening with confidence, I won't get into needing haircuts or hair gel or any of that stuff, because I definitely need some of that to reopen confidently. But, as far as being able to open with some level of comfort for, getting employees and customers and students and parents and patrons and visitors and guests, depending on whether you're enterprise, venue, stadium, school, whatever it is. So, we ourselves are kind of in an interesting situation. Our headquarters are in a high rise. And in our high rise, basically the problem is the building keeps having COVID outbreaks. And so there's a little bit less control when you're in a building that you don't fully control. Now, on balance, a lot of our customers have the entirety of the building, or schools have the whole campus, stadiums have the whole venue. And so in those settings, I think it's a little bit easier. So I'm not going to dive too deep into what to do if you don't own the entire structure. What I would say, and what we try to do with that, is limit the number of people who are going in, and also, encourage employees to come in during off hours. So knowing the flow of your buildings. In our building, we've got elevators and things like that. And if you know that usually those elevators get hit pretty hard at 9 a.m., encouraging employees who are going to have to go in at 8:30 or 10:30, 5 o'clock, everyone clears out the building. Well, maybe your staff should clear out at 4:30 or 6:30. And so there are little things you can do like that are a little bit more structural, where you don't have full control of the ingress and egress process. Separate from that, basically about when it comes to reopening with confidence, there's a few things that we've got to take into consideration. And basically when you're looking at things, the questions are, and this is what it really comes down to, right? If your staff is sick, if students are sick, if visitors at your business are sick, you're either talking about lost productivity or just bad word of mouth and liability exposure, and people are not going to be able to come in. And so really what you're trying to do here is, how do we keep sick people out? And when you talk about reopening with confidence, that's really what it comes down to. How do you keep sick people out? And if someone who's sick got in, how do you find out who they were, who they crossed paths with, and limit that spread, which basically comes down to identifying and isolating. So the first piece is, how do we keep sick people out? And the second piece is, how do we identify the few that somehow fell through the cracks? How do we identify them, remove them, and isolate, people who are affected? So, we as a company have come at this with kind of a 4-part solution. I'll be talking about what we're doing. There's a lot of companies out there doing a lot of things. We think that these 4 pillars kind of hit the main points of what you need to do. The other thing that we've also tried to focus on, and we recommend and encourage this if any system you're looking at, it's the hope, I should say, I was going to say more, but basically just the hope that COVID's going to go away at some point, whether it's 3 months, 6 months, 9 months, 12 months. We're hoping that it's going to get to a point with the vaccine and, or, there's new treatments that it will get to a point where it's somewhat manageable. So when you're looking at it, whether it's a business, a school, whatever it is, any solution you're looking at needs to be cost effective, right? Because no matter what you are, you're probably understaffed right now, probably have had your budget impacted. And so now's not really the time to be adding increased cost. And so one of the things that we've done and we've approached this with is, to the greatest extent possible, we've built off it from the emergency communication platform. And so if you look at systems, I mean, some systems that are coming in with COVID functionality, they're just charging 6 figures, 7 figures just for COVID functionality. And I don't know if that's necessarily a viable solution to businesses that have seen, their budgets and their businesses hit. And so what we've tried to do is, to the greatest extent possible, if not entirely, depending on the package that a site might have, layer this into emergency communication so that you're not actually incurring additional costs to the greatest extent possible when having this sort of functionality. So with that leads into what kind of functionality we're talking about. Well, let's talk about the first pillar of this. And the first pillar of this, again, is keeping sick people out. So how do we do that? It's actually kind of funny. And Todd, as an EM, I mean, I'm sure you've seen a fair share of this. People have these ingenious ideas, right? Show up to a business, the employees show up, wait in line, 50, 100, 200 people, and answer a questionnaire. Well, that sounds great until the fact that you're waiting in line with 200 people, and when person number 37 turns out to have COVID when they answer that questionnaire, well, you've been in line with that person for quite a while. So, maybe on-site screening is not the best of ideas. So what we believe is a really good idea is to basically create an off-site screening. And again, you got to have something that will acknowledge on-site. You might have a guest that pops up, a student that pops up, a vendor that pops up. So you've got to have something that can address the on-site issue. But fundamentally, on-site screening is not a great idea, because if people are sick have to come before they get screened, that's a problem. The other thing that people have done too, and again, these are just things we've learned from the market, people are doing things like putting thermal systems, taking temperatures, this, that. Guys, people have got 104-degree fevers, don't want to be at your business or at your school. They don't want to come. They're sick. They don't feel well. People are asymptomatic, don't have fevers. So people are spending a lot of money on these sorts of thermal systems. You don't actually get a lot of bang for your buck out of that. And we know that because the sites we're working with have so many outbreaks where they're using pre-screening and contact tracing, and the person didn't have fever when they were sick or when they were at the site. So, I guess it's something to make you feel better, but I don't know if that's where the dollars are best spent. So what we believe in doing is off-site pre-screening. And with that, you have to have a system that a lot of people like apps, and you got to use apps, but also it's something that should be able to be done without an app via text message. You're basically capturing entire populations, no matter who they are, where they are, what they're doing. So our particular solution for that, again, we're not the only solution, but our particular solution for that is to do something where it's an automated push out every morning. And we feel with that automated push out, you're basically pre-screening people both with a direct question, are you positive, yes or no, and then secondary risk factors. Now, that we believe is the best way to go about pre-screening. We also believe it's important to have different criteria on that screening for sensitivity. So what does that mean? That means certain sites want to see the symptoms that people had. Other sites do not want to know the symptoms. They just want to have a pass-fail. So you got to have customizability in your platform. Mm-hmm. Other things that you've got to look at too when you're talking about pre-screening is some sites want ingress control. So do you have something like a QR code that you can have? Do you have a red screen, green screen kind of system, visual? So you've got to have different variabilities so that you can facilitate whatever the process at the site is. The most common system configuration of the platform we've seen is an automated notification every morning. People get a green screen with a QR code and they're able to ingress. Now, there is one other thing that I have to highlight that a lot of the contact tracing systems we've seen out there are not doing and pre-screen systems are not doing. We also have telehealth, and so we're unique in this, and this sounds like a little bit of a pitch, but you got to make sure that whatever you're using is HIPAA compliant. You're talking about medical information that's going through here. And we had the luxury of being HIPAA compliant because we also have telehealth. You've got to be careful with what you're pushing, being HIPAA compliant. And some sites will say, well, there's variances the government has waived. Yeah, okay, but those things are temporary. They vary from state to state because the government's doing stuff on the federal level. States are doing different things. It's probably a best practice to be HIPAA compliant all the way across, not having good data, privacy practices, and all those things. Now, the other thing that kind of comes into here too, and again, this is something funny we drew on from the emergency communication side, but you probably want to have real-time translation in there. People don't necessarily speak English as a primary language, whether it's staff, whether it's guests. You should probably have something that can provide real-time translation, because you know what? If you got an employee who doesn't speak English as a primary language, it's still possible for them to have COVID. So COVID doesn't follow language barriers. So these are the kinds of things when it comes to pre-screening. Make sure it works via an app. Make sure it works via text message. In our particular scenario, we've also made sure it's fully accessible to the hearing and visually impaired. You got to make sure you're capturing vulnerable populations. Make sure you're bridging language barriers and easy ingress and egress. So that's what we believe is a good solution with pre-screening and a best practice.
There's a couple of questions that came in regarding some pre-screen stuff, and we'll go with David first, and I'm going to kind of combine both of his.
Sure.
Things. One is that he was thinking, and I agree with him. He says it's with the temperatures, sometimes it's perception regarding taking temperatures. And I know that we've talked about this in the past where temperatures are kind of more of a late stage. If it's an elevated temperature, it's more of a late stage showing on the symptoms. And then, but he does ask, he goes, with offsite testing, do you need immediate results? And he goes, is this prior to coming to work/school every day with question marks?
Yeah, so these aren't necessarily tests. For better or for worse, the reality in our country is that we don't have sufficient testing. So, that's why the preliminary question is, have you tested positive, yes or no? The secondary questions, though, are really, I think, where the meat and bones of this. You're not going to have a lot of people who say, yes, I've tested positive to COVID. You're going to have people who report positive to the symptoms and have been around people who have been tested positive, etc. And that just unfortunately is the reality of where things are at. So that's why those secondary factors are so important. With the temperature thing, it is a later stage symptom. Also, depending on, there's so much data out there on this on the medical side, but some studies have shown as few as 10%, some studies have shown as high as 40% of people have fevers. So if you're looking at the 10% mark, even 20%, that means 80, 90% of people are not exhibiting fevers at any stage. And that's assuming they're even symptomatic. So, it is something, it's like perception, right? I remember when I was in school many years back, they used to say that DARE actually is not very effective at stopping kids from doing drugs. If your experience was anything like mine, they'd come into class, give you a coloring book, tell you drugs make you feel fun, and tell you not to do it. So that was our DARE education. But you've got to have something, right? Because without it, you're not doing anything to address it. So that's kind of, and we won't get into it. If you want to have it, do it. If you don't. But the screening questions are probably a better approach.
And then Michael asks, is not screening a snapshot in time, quote unquote, when they leave or was exposed short time earlier or later? What is the thought on on-site screening reliability? That's a good question. It's kind of outside of the technology side of it, but I think with this one here saying, you're right, Michael. When you go and get screened, it is a snapshot. It isn't, a week later, and there is that incubation period that you have of a week or so, or up to 2 weeks. Still not sure. They say 14 days, right? So it is a snapshot. You're absolutely right. So you could be healthy one day, right? So I come into work, I feel great, I have no exposure. I go to the grocery store and I get exposed by somebody. And then I'm sick again. So it is a continuous.
And Todd, this is why, we always talk about having multi-factor. Pre-screening is one tool. It's not the only tool.
Right.
That's why social distancing and masks are so important too. If you take a look at, there was an incident a little while ago at a hair salon, right, where there were dozens of people who went in. Both the hairdressers were COVID positive. Everyone was wearing masks. Nobody was infected. So, masks and social distancing should always be followed, because these tools will help mitigate risk, isolate risk, and extract risk. But these systems are not perfect, and that's why those secondary measures are just as key.
So Alice asks, are you pushing the survey out to all employees or just those working on site? And they have a
So
they have a
here's an
blend.
interesting question.
Yeah.
Yeah. So basically, it is recommended to generally do all employees because a lot of sites are doing A/B, and given the 7 to 14 day incubation period, it's important to know someone could exhibit symptoms today, who hasn't been in the office for 3 days but was 5 days ago, right? So you kind of don't know, and that's why it generally, as a best practice, it is good to have all employees who are routinely coming into the office to have that screening process.
And then Vince asks, will you screen with questions like, have you recently been in large gatherings, crowds, closed spaces, example, airplanes the last 14 days? And I think it's up to the person who's asking.
Yeah, it's completely up to the site on what they do. You're basically putting in risk factors, and we've really seen these surveys evolve quite a bit. In the beginning, they would ask you if you've been to hotspots like New York. I mean, now the whole country's a hotspot, so those kinds of questions have been, removed. So it's you're basically asking symptomatic questions, and then you're also asking if you've been around anyone who has been COVID positive, and that's basically the high level of what the secondary questions are encompassing these days.
Sure thing. Now, I have a couple questions that I kind of put down, and I know this kind of going into the COVID or to contact tracing, and just to kind of give some historical context to contact tracing for those that don't know. Contact tracing has been around for a long, long time, and a matter of fact, we've used contact tracing in the sense that we know who the first Army cook was in 1918 to get those guys in Kansas that got sick that spread the 1918 Spanish flu, and I put in that quotes because it really should be an American flu, around the world. So, I mean, that's contact tracing basically. The questions that come across with contact tracing, and you see a lot of articles written, is regarding privacy rights and things like this. Talk a little bit about contact tracing and
let's dive into that. Let's dive into that. So, contact tracing is a really interesting concept from a technological standpoint, right? The better you are at digitally contacting people, the more accurate and the more valuable the data is. But you have to balance that with privacy, right? So our approach that we've taken, being a kind of a privacy-centric approach, we feel, is we're doing 2 levels of contact tracing, and we're putting limits on those. So the first level of contact tracing is we're doing phone-to-phone contact tracing. And that way, if you're near people for a certain period of time or whatnot, then you've got that digital connection. The second type of contact tracing we're doing is phone to zone. And that really captures something that I feel like a lot of people are not really hitting on, which is the near miss. If you're in a conference room for an hour and you're sick and you're in there breathing, aerosolizing, all that stuff, and you leave and a minute later someone else comes in, your phones never cross paths. Your tracking tags never cross paths. That air is very much still infectious. Those surfaces are still infectious. So you have to have phone to phone. You should also have phone to zone. So we believe it's really important to have 2 levels of contact tracing. And that also lets you run reports to see who was where and what. But you have to do this in a privacy-centric manner. And the way that we have approached that is, first of all, we geofence the contact tracing. So we're not allowing contact tracing everywhere, anywhere, and at all times. We're only allowing contact tracing within the geofence of your business, your school, your venue, your stadium, your hotel, whatever it is. So we're limiting the geofence tracking to that site. The second thing that we believe is really important to that is not allowing HR to track all employees at all times for any reason. So unless someone has reported a COVID positive response, that then flags the admin to run a contact trace against that user and where they've been. But without that, you can't. So, if Todd is a troublemaker and he tends to hang out by the water cooler, you can't try and see who his accomplices are and who's hanging around. Steve and John are hanging out with him at the water cooler every day, and so you can't do that. You can't kind of tag the rat pack, right, and figure out who's out there causing trouble. So the idea is to limit tracking in the first place to only the site, and secondarily only run reports on people who have affirmatively reported in a COVID positive response. So phone to phone, phone to zone, so you're capturing everyone. Work with phones, work with tags, work with phones, work with zones, and make sure it's limited to the site. And in addition to that, only tracking people who've tested positive. So I see we've got a few questions and some hands raised in on that, and happy to dive into that and have a discussion a little bit about contact tracing.
Yeah, absolutely. So Susan, Vic, I'm going to ask you to put your lawyer hat on, right?
Yeah, okay.
And, for those of you guys who don't know, Vic is also a closet lawyer. So from the legal standpoint, is it better to send out surveys to everyone in case they do come on site? And how do you provide a complete picture for your total staff and employees?
Yeah, so you definitely need to be sending out to everyone. We really do recommend that. And in that vein, what our system does, it actually allows reports and analytics. So it'll show you how many people responded, who responded, what the answers were. So if you want to provide abstracted analytics for your site, you could do that without disclosing any private information. You could say, we have 7,000 employees, 13 have tested positive or reported positive in the last week. So you could have abstracted information. Knowledge is power. And what we have seen at sites, a lot of sites, they're trying to do things like social distancing, masks, whatever. And as sites, sites often we see them not impacted, boom, impact. And, when you share that impact, you definitely get people being more adherent to social distancing and mask wearing and all those kinds of things. So absolutely.
So Mark has his hand raised over here, and the question is there a recommendation threshold to notify local health authorities of test positive results among employees? And I guess that same thing would be kind of put that back into the contact tracing. When you do, as an organization, have a positive, so if I come in positive, it shows that I'm positive. Now, what's your legal responsibility, and how do we report that up to the public health?
That's a really good question, and I hate it when people punt on webinars, but I'm going to punt on this for one very specific reason. The rules from state to state are so different that the answer literally varies from you have to tell to you're not allowed to tell. So I would strongly recommend talking to local guidance on there, because the advice that I will give on that, it's so variable. There's not a one size fits all answer to that.
Absolutely. Yeah, it's a good point too. And sometimes it's from county to county too, as well, not just from state.
It really is. And then not just county to county. In the county, there's different levels, whether you're a school, an enterprise, a hospital, a venue. I mean, it's nuts how much variability there is in that. And I do see another question here from Michael. And I'm actually going to dive into that question because that's actually the next thing I was going to talk about. So we've talked about pre-screening and we've talked about contact tracing.
Well,
I'm going to
let me read the question real quick so that everybody who's not seen that.
Sure.
So he's asking for reopening a facility seems currently thought as those cleaning all surfaces continue may not be the best use of funds. Should schools, robots, say spray or UV, etc., for specific areas? So it's basically how do you sanitize the area and how does that work? So
yeah, and this really, so we talked about pre-screening, we talked about contact tracing, and so basically, I think the thing to talk about next is the third and fourth things that we see as the arms of helping reopen safely. And the two things we're doing there, the first is we're doing population density monitoring. And it's really important to make sure social distancing is being followed and make sure that not just population density in any specific area, but also understand where people are and what kind of flows of traffic you have through areas. So knowing where people are and the flows of data and people are really, really important, which leads to the fourth thing, which is sanitization confirmation. And so what we've done is we've taken our asset tracking technology and used it to tag sanitization confirmation, coupled with our contact tracing and the population density. And so what you're able to do is if you're able to see that certain areas had nobody going through them, then maybe it's not a great use of resources to clean those areas as frequently. If no one's gone through a room for a week, why would you clean it? In addition, if there are areas where the traffic is very high, maybe cleaning hourly is beneficial. Also, so not only does this help you maintain a routine of cleaning procedure based on real-time data of people and traffic and all that, but also if someone has tested positive and through that 2-level contact trace, you know that they were positive in zones 1, 4, and 5, you can ensure that there was proper sanitization at zones 1, 4, and 5. Maybe you go in with a deeper clean or something like that. Sure. So to that point, absolutely, these things are very valid. And that's why we always say best data wins. The better the data, the better the analysis, the better the action item. And so it's really important. Pre-screening keeps sick people out. Contact tracing, once someone is sick, know where they've been and isolate people who've been sick and exposed. Population density, know where people are and where they're flowing. And sanitization, deploy resources strategically into cleaning the areas most affected.
So Paul asked, have you seen an interest in telehealth systems being used at conferences, expos, and other event planners and marketers? That's a great question, Paul. I mean, I know that, the expos and stuff like this have had some, obviously, closed them down. There's a huge money loss right there with that, and all the, especially the emergency management events that have been closed in the last few months. That's a really good question. What do you think, Vic? Is that a good use?
I think so. And I mean, here's the thing. We have a telehealth platform, and I think this is the thing that you've got to consider with telehealth. We have a chief medical officer as well too. He's also an active ER physician. Here's the bottom line of it. If you have symptoms that are COVID related, they tell you probably have COVID. There's not enough tests. Even if you go to the hospital, if they're not admitting you, they're not testing you. So I'm not a doctor and I don't want to give medical advice. Telehealth is important. It can provide you peace of mind. Ultimately, if you're having difficulty breathing or any life-threatening conditions, you probably need to go into the doctor's office or an ER. And if you don't, there's nothing they can do for you, and likely probably can't even test. So that's kind of the thing. So telehealth has seen a very large uptick. We have seen immense traffic increase. Most of it, I think, is for peace of mind over actionable medical, treatment.
Sure, but I think it's a good idea though, with the idea of having some sort of in-house medical group.
That is, yeah. I mean, that does bring value because it provides access. And actually, interestingly enough, what we've seen with telehealth. So historically, we've seen going to medical providers, but more and more organizations are setting up a triage, or they're training people on some level of something, and so they're localizing the triage system of the telehealth into their own organization for symptoms and what to do if you have any of the symptoms. So there is a growth of that, absolutely.
Yeah, and we're also, I think the idea of using it at institutions of higher education and maybe even K through 12, maybe more through the high school, where students can actually talk to somebody, and kind of, again, answer questions and whatnot in a timely manner. So Julie has a question. Has there been any thought of creating different zones within mechanical space systems in order to try to contain infectious air? For example, areas that may be occupied by both employees and visitors, such as lobbies and things like this, and not always isolated, like HVAC-wise, that type of technology, rent-a-cars, things like that.
Yeah, I mean, it's kind of interesting with this. So it kind of depends on where your building is. Our office building is a beautiful office building, ocean view. I mean, stunning. It was also built 50 years ago. And HVAC system is not particularly advanced. The building has asbestos in it. And there's not a lot they can do. There's not a lot that they can do. And they have been notifying us pretty frequently that people are getting COVID in the building. And it's interesting. There'll be someone who got it someone diagnosed with it on floor 3, and then people on floor 4 were exposed. Someone had it on the second floor, and then the bank on the bottom floor was exposed. So it's definitely circulating through the air vents. I'm aware that there are buildings that are newer that have UVC light treatments and or more advanced filtration systems. In our building, all they're doing is they're trying to flush the air out faster, which is fine, but it doesn't do a lot to capture anything. And I don't know if that actually, I mean, as you're flushing the air in and out, I don't know if that even circulates and it doesn't let the aerosol settle. I don't know. So, I mean, that's a great question. That's a great question. That's a great question.
Man, lots of good questions coming out of the group, and everybody, thank you so much for participating and asking questions. Again, please keep them coming, because I think this is a very important conversation. I mean, we have a lot of emergency managers on this conversation. We have a lot of administrators in on this conversation, and to really kind of flesh out some ideas. And everybody, I mean, obviously, as smart as I think I am sometimes, I don't have all the answers and I don't have all the questions. So I'd love to have you guys bring it in. Speaking of systems, how does like the COVID tracing system work? In general, like with outside just the technology, how does the entire system work? Do you know?
There's some fundamental premise in contact tracing. The idea is that someone has a certain value, and that value here would be positive to either COVID or risk factor. And accordingly, you're trying to find out anyone who may have come in contact with them. Specifically, the interesting thing when you talk about it more generally is it's all based on risk factors and risk tolerance. And we're seeing differences in this. So for example, what does that mean? What that means is in certain areas, people are following CDC guidelines and they're saying, okay, 15 minutes of contact with an infected person is what we're deeming a sufficient risk factor that you were probably exposed to the COVID infected person. Other sites, though, are saying, well, we're just going to say if you just cross by them, we're going to say that that's sufficient. Other places are saying, well, we want to see 30 minutes to an hour. And this really is varying based on the type of place it is. So, you go into a standard office building and they're generally following this 15-minute CDC guidance rule. You go into schools and they're following more historically, maybe like a 15 to 30-minute range. And they're saying, maybe kids are not as susceptible. I don't know that the science backs that anymore. But, some people are looking at that. You're going into more outdoor-ish venues and they're putting thresholds at 30 minutes to an hour. So basically the fundamental of the contact tracing is you as an organization, based on some science, medical information, whatever, are saying this level of exposure carries this level of risk. And that's the amount of tolerance that we are accepting before we notify people that the tolerance level of risk for this site has exceeded. And that's basically what's going on.
It's absolutely a systems thinking process that we're going through with putting this together. And speaking of that, what does a typical deployment of the Titan HST app and hardware look like?
Yeah, that's a great question. There's a lot of people who are trying to come up with solutions. And again, looking at businesses and different use cases, we believe that having flexibility and multiple options is the best way. So, if you take a look at something that's quick, cheap, and easy, you can always do a software-only solution. And with that, you get the phone-to-phone contact tracing, you get the pre-screening. If you want a more nuanced solution, you can also add hardware, which then gives you that second level of zone-based notification, tracking, and whatnot. So for software solution only, you're literally basically flipping a switch on the server. For zone-based, we generally get some sort of building schematic and then provide passive beacons. We have active ones too if you're going to do asset tracking and sanitization. But you can either do passive or active beacons and basically monitor people with zones and or also devices and tags. So there's a solution for everything. It just depends on what type of solution the site is looking for.
And what type of organizations have you seen that have been really active in doing this contact tracing and also, just using the services? It's been interesting, right? So you've got a few different sectors that are probably most heavily engaged in this. And I think those are the sectors that it's most difficult to do things remotely from. And so you're seeing education very heavily. You're seeing stadiums and venues, even though they're mostly empty, the staff at stadiums and venues with a ramp up for when guests are able to come in. Casinos and hospitality, you're also seeing very high penetration. Enterprise does use it, but a lot of enterprise is trying to not come back till January, and some like Google have announced till June. Some like Twitter all the way through next year. So the enterprise that's coming back, you're seeing it as well, but a lot of them are trying not to. Now, the other interesting area is you're seeing a really high adoption in hospitals. And this might have been the straw that broke the camel's back. Hospitals have dealt with outbreaks and other infectious diseases from SARS to MARS to Ebola, etc. And I think with COVID, you're seeing contact tracing being brought into hospitals for the next level. We had H1N1 in the past, and really something that is going to empower hospitals to have better contact tracing across kind of any and all future, not necessarily pandemics, but whatever the next virus is that comes through. What are some of the challenges that you see, and this is kind of a global question, that you see facing organizations today? You're a leader of an organization. What do you see some of the challenges facing an organization today that we didn't see before and that we're going to have to go on forward with, specifically with COVID, maybe even, say, other communicable diseases that might be coming behind us?
Yeah, COVID is really interesting. It's been very politicized. If you take a look historically, things like the flu, and I know if you all the way with 1918 and there's masks and all that stuff, but in more recent years, you know, there's been a level of acknowledgement of things like flus and colds, you know, cough or sneeze into your elbow, wash your hands. If you're at risk, get a flu vaccine. You've got things like that. And if you take a look at other risk factors, people are doing things for active shooter. People have been training for fire drills. I mean, how often do you hear about anyone dying from a fire in a school or a building anymore these days, right? I mean, Todd, I think EM Weekly has done a whole sector on this, right? With earthquakes and fires. I mean, to the extent that an earthquake is unexpected, you can't do much. But with the fires or not, people don't really die from fires anymore.
Right.
Why? Because it's training, 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 training. The really interesting thing with COVID is it's completely politicized, and half the country believes in it, half the people don't. And so when you're in a scenario like that, um, you know, it's tough because it's hard to train and prepare for something that's invisible and that half the population doesn't believe in. And one of the interesting things, you know, coming back with my lawyer hat on, there's been a very substantial uptick in litigation against organizations, both by people who got sick with COVID at the organization and people who caught COVID at the organization, took it home, and one of their loved ones in their household got sick or died. And the question has turned to, has the organization done enough to keep people safe? Do you have Purell dispensers? Is the air clean? Is there social distancing? And so it's an interesting thing. It's an interesting thing. And I think these types of technologies and approaches, nothing's perfect, but it helps mitigate large chunks of risk. And I think there's something to be said for that.
You know, that kind of parlays into Julie's next question, is using the example of high-rise buildings. Would the software, hardware be utilized by individual companies / tenants, or by the building owner property manager? Is there, you know, and then she goes on to, if it's only the individual company or tenant, are there ways to connect with other tenants in the building? That's a good question.
So that's a great question. So here's what we're seeing with these high rises. There are certain landlords that are very organized and very corporate. Those are deploying it portfolio wide and through all the tenants throughout. There are other landlords that are not as organized. And there it's being left to internal offices, and sometimes multiple offices on multiple floors are kind of creating their own, you know, COVID militia, if you will. So yeah, there's a lot of variability in that. Absolutely.
I'm going to take this question, actually. Susan asked, how often do you see the reoccurrence of the next pandemic? Should we be expecting another 100 years, or is it 2, 5, 10? What's more realistic? You know, realistically, Susan, when it comes to pandemic, this is something that as emergency managers and public health people, we've been really concerned about for years. You know, we've dodged the proverbial bullet a couple of times with MARS and SARS and H1N1. You know, they just, for whatever reason, due to either earlier indications of this and we took actions, or we just got lucky that they didn't take off. I think specifically with COVID, there's a lot of, it's a unique disease necessarily, and it's what's was called a novel virus, which really made it harder for us to figure out what was going on. Obviously, the coronavirus itself has been around. I mean, if you take a look at a can of Lysol, it says it kills coronavirus. This is the novel coronavirus, which means that some of the enzymes and stuff in it were different, and it really took to the lungs compared to other things. Where the difference becomes is the human-to-human transmission of diseases, and with the rapid spread. And a couple of things that we have going on here that's unique, not necessarily unique, but faster than we had in the past, is the fact that we can jump on an airplane and in 12 to 16 hours be across the world, right? You know, so from China to the United States, and from the United States over to Europe, and so forth and so on. So you know, that's part of the issue. So I think that we need to keep doing, when I say we, the collective we, the world, if you will, monitoring of diseases coming from unique spaces. And you know, there's been some talk about the fact that since we're having thawing going on in some of the northern Asia areas and Siberia and whatnot, that there might be some other unique diseases coming out of there as well. So we just got to keep an eye on this. So I would say, I would think we're looking probably much every 5 years or so that we're seeing something pop up on the radar, which is what we're concerned about. I don't know if you guys...
And Todd, let me jump in on that too,
sure,
right?
Please.
This pandemic didn't, and I don't want to get too political or dive too deep into this, but we talk with a lot of healthcare and service a lot of healthcare clients and entities. So we've seen from the front lines of this. And if you're not in the healthcare space and you're not one of those large healthcare entities, this thing seems unique. Coronavirus is different. It's not necessarily as different as people think. If you take a look at other things like SARS, MERS, you look at H1N1, there were nationwide campaigns against it. There was contact tracing, there was isolation. H1N1, there were entire campaigns about this is a bad flu, the swine flu, right? People, it's a bad flu season. Wash your hands. You know, if you're sick, stay home. Vaccination rates went up. I mean, there was a lot. You look right now, and 2 years ago, the CDC's rapid response team to pandemics was dismantled in the country. And now we're 7, 8 months in, and there's still no response, right? There's no federal response. And so if you take a look at other countries and what has occurred in other places, it's not to say that it's non-existent. I mean, it was bad. But you look at someone like Italy that shut down. You look at something like China. China's death count, and China's a lot more populous than us, is 4,700. Our death count is 180,000 and counting. So if you take a look at how China and other areas have reacted, again, due to population densities, they've had SARS, they've had MERS, H1N1. There's a much more, if you just look at pictures and video from just last year, you put this up, a lot of people wear masks. A lot of people are very cognizant of those kinds of processes. And we don't have that here. So to Todd's point, there's a lot more travel, there's a lot more interaction. So the likelihood for pandemics is much higher probably than it's been in the past. Similarly, for those reasons, you need to have the infrastructure to relate to it. And if you do, we can probably nip things a lot faster than what's going on.
You know, that kind of brings us around to the top of the questions again, and we sort of alluded to this in the beginning, but how do you see us, the nation, the world, kind of getting back to normal? And I put that in air quotes.
Yeah, I think there's two ways to get back to normal, right? And there's two arguments that you hear about this. The one is that you basically remove all restrictions, and you just say, look, we're just going to open things up and we're just going to go for it. And it depends on what you talk to, who you talk to, but they say anywhere from 0.5% up to, you know, as high as 4%, depending on the population of death rate with this. They say another 10%, maybe as high as 20% with critically ill symptoms that remain. So it comes down to a country and its values. If you say, look, let's take a 1% death rate, for example, which is on the lower end of the range. And that's something that's, you know, multiple X the flu season. And if you say, look, there's 330 million-ish people in the US, 1% is 3.3 million dead. 10% is another, you know, 60 million who'll be chronically ill. We're going to let 3 million die, 60 million be ill, chronically ill. Say that, and you can just open up tomorrow and move forward. If you say we want to contain things and you know, 3 million dead, 60 million chronically ill is just, it's too high a price tag to handle, then you're going to come down to mitigation and treatment. Treatment is purely medical. We can't do anything about that on this call. Mitigation is a vaccine and slowing the spread. Until you have a vaccine, or some people may not be able to get the vaccine, then you've got to slow the spread. And to slow the spread, you've got to do things that physically slow the spread, which is social distancing and masks, and identifying people who are sick and pulling them out of the population, which is pre-screening and contact tracing.
Right.
And that, I think, is just, you know, whatever your affiliation politically is, those are your three options, right? You let it run rampant, you do social distancing, and or you attach some technology. And based on what you want to do, those are your three options. But there aren't, I mean, that's it.
Absolutely. It's, I think that together, if we all band together in this, I think we're doing a pretty decent job and really put our heads together and move forward. And I think using technology such as the contact tracing that we have and things like this, it's really going to help open things back up in a timely manner. You know, Vic, we're coming here close to the end. I'd like to give you a few minutes kind of just to talk a little bit about what's going on at Titan HST and how you see Titan HST fitting into a solution.
Yeah, you know, I mean, we're obviously a vendor, we're a company, and And there's a number of solutions that are out there, and we think that our solution is unique for the reasons mentioned. We see the COVID technological solution as a four-part solution, with first being pre-screening, second being contact tracing with 2 levels of contact tracing, the third being population density monitoring, and the fourth being sanitization. So we really see the COVID response as a four-part response. We also believe that to the greatest extent possible, anything and everything you can do to not add cost to businesses. And, if your clients have fully deployed hardware, software, we're able to get them into COVID at no additional cost. Clients who've got some level of software or hardware, we're able to upgrade them with additional server capacity and some additional functionality. But really, our approach to COVID, and we think it's a good one, is minimize cost to businesses and organizations, and minimize costs. And whatever you have, if it's something that can be utilized in a larger emergency communication context, it's something, Todd, we really didn't get into on this call, but just because you got COVID doesn't mean you don't have other emergencies. Right. And California is on fire right now. In addition to that, last week I had rolling power outages. We've got apparently 2 hurricanes for the first time ever hitting the Gulf Coast, with, they're saying, 15-foot high surges 30 miles in. The East Coast's been hit. I think because it's 2020, we're just a week away from a tornado and an earthquake. I don't know where those fist-sized wasps went, but I'm sure they'll resurface it being 2020. So I think you really got to prepare for emergency communication. And the thing is, the natural disasters haven't stopped just because there's COVID. In fact, it's made it harder. It's made it harder to basically respond to those emergencies, given that there's COVID. And so I would say, have an emergency communication system that also addresses COVID, and find one that is going to hit the entirety of what you're facing. And that, I think, is kind of the punchline from all of this. It doesn't have to be overly costly. It doesn't have to be burdensome. And if you utilize it properly, it can consolidate multiple platforms into one and provide ease of use.
Absolutely. And you're right, Vic, just to kind of piggyback on what you're saying regarding the other disasters coming, the fires and the floods and the tornadoes and hurricanes that are hitting us hard right now. Sheltering is a whole another challenge that we have with taking care of people, and at least having some way to screen them and take care of them. I think is going to be very, very important to keep people safe during this time.
Absolutely.
So, if anybody have any last minute questions here, I want to be value of your time. I told you we're going to be here for an hour, and we're getting close to that hour time. Please go ahead and pop in. And Vic, thank you so much for spending time with us this morning. I know that you super busy there, and realistically, thank you for answering the questions, and also for creating such a great product.
And Todd, with that, what we'll do? We'll give people the greatest gift of all these days, which is 10 minutes before their next Zoom meeting to grab a bite and run to the restroom. So, thank you for your time. Stay safe. Stay well.
Absolutely. Hey, everybody, just before I let you go, just let you know, we will be sending you an email with some resources for you. So thank you for being here. A couple checklists and an article on what we're doing. COVID, as far as what we do, COVID. And yeah, I think take some time and go get a cup of coffee or something.
Yeah, absolutely. Thanks, guys. Take care.